Usually when we talk about getting a medical diagnosis, there is this expectation of precision.
Right. Like, it should be straightforward.
Yeah, exactly. It feels like engineering. Like you fall down, your arm hurts, you get an X-ray, and there's that jagged white line on a black
Where the
background.
doctor just points at it.
Right. They point at it and go, there it is. That's the broken bone. Broken or not broken.
It's very binary, which, gives us a sense of control because we really like things to be visible. We like to categorize the problem.
But then you step into the world of pelvic health.
Mm.
And specifically, we're talking about vaginal sensation today. And suddenly, that X-ray machine is just utterly useless.
Oh, completely useless.
We're looking at a diagnostic landscape that is just incredibly murky. You have women experiencing these sudden or like gradual changes. Maybe it's excruciating pain or complete numbness or just a total loss of arousal. And the big question we're looking at for you today in this deep dive is how doctors actually figure out what is going wrong in there.
Yeah.
Specifically, can nerve testing actually help evaluate these invisible sensation changes?
Yeah.
Or are we just, grasping in the dark?
It's a vital question to ask, really, because you are dealing with the absolute definition of diagnostic muddy waters here.
Yeah.
When you look at the pelvic floor, you aren't just looking at a bone or a simple joint. You're looking at this highly complex, completely invisible web of muscles, connective tissues, and a massive network of nerves.
The whole ecosystem.
Exactly. So when someone experiences a dramatic sensory change, whether that gets triggered by childbirth or, the onset of menopause or some chronic pelvic pain syndrome, doctors have to find a way to map that invisible wiring.
Right. They have to figure out where the short circuit is.
Yes. And to do that, they rely on a really fascinating and honestly sometimes highly controversial mix of old school physical exams and these really advanced neurophysiologic tests.
Okay, well, let's start with the wiring itself. Because to understand how a doctor tests a nerve, I feel like I need to picture what we're actually testing.
Sure. So the star of the show down there is the pudendal nerve.
The pudendal nerve.
Right. If you want to understand sensation in the female genitalia, this is the crucial pathway. It mediates somatic sensation.
Meaning what exactly?
Meaning it handles both the sensory feelings you get and the motor functions of the muscles. It originates right out of the sacral spinal cord, so down at the very base of your spine.
So way down at the bottom.
Yep. And from there, it snakes its way through the pelvis and splits into various branches, and those branches serve the clitoris, the labia, the perineum, and the perianal skin.
So it's basically the master switchboard for every feeling you have in that entire region.
That's a really good way to put it, but the issue is its geography.
Because it covers so much ground.
Well, because it has this incredibly long, tortuous path through the narrow, crowded space of the pelvis, it is highly vulnerable to damage. It has to navigate around ligaments and bones. Oh, I see.
So it can be compromised by acute trauma. Think of the extreme stretching and tissue distortion that happens during vaginal childbirth.
Right.
Or it can be damaged by prolonged, repetitive compression.
Like what kind of compression are we talking about?
Years of competitive cycling is a classic example.
Oh, from the bike seat.
Exactly. The pressure of a narrow bike seat directly against the perineum over time can literally crush the nerve. Even prolonged sitting at a desk for years can contribute.
Wow, just from sitting.
Yeah. Or the nerve can physically get trapped by the ligaments or the tight muscles inside the pelvis itself. That condition is known as pudendal neuralgia, or pudendal nerve entrapment syndrome.
Okay, so if I'm picturing this, it's like having a central fiber optic cable running through the walls of a house.
I like that analogy, yeah.
Right, so if an earthquake happens, say, childbirth, and the walls physically stretch, that cable is going to get pulled and the internal glass might fracture.
Yes, the signal gets disrupted. Or if someone drops a massive, heavy safe right on top of the cable, which would be like the nerve entrapment from a tight ligament, the signal gets distorted.
Exactly.
So it might show up as a dropped internet connection, which I guess would be numbness. Or the damage might short-circuit the system, causing this blaring, malfunctioning alarm to go off.
Which would be the chronic pain. That analogy hits the nail on the head. And that blaring alarm of pudendal neuralgia manifests in some very specific and frankly bizarre ways.
So?
Well, clinicians actually use a checklist called the Nantes criteria to identify if the nerve is entrapped. One of the hallmark symptoms is perineal pain that gets significantly worse when the patient sits down on a normal chair.
Okay, that makes sense.
But it immediately improves when they stand up.
because standing takes the weight off the pelvis.
Yes, but here's the really specific part. The pain also improves if they sit on a toilet seat.
Oh, because there's a cutout. There's nothing pressing against the center of the perineum.
Precisely. The pressure is distributed to the thighs and buttocks, so it leaves the pudendal nerve completely free from compression.
That is so specific, but it makes total physical sense.
It does. But perhaps even more distressing than the pain is a neurological phenomenon associated with this nerve damage called allotriesthesia.
Allotriesthesia. I don't think I've ever heard that term.
It translates roughly to the sensation of something foreign.
Like a foreign body.
Yeah, patients with severe pudendal nerve compression will often report the distinct, maddening feeling of having a foreign object. They usually describe it as a golf ball or a tennis ball, permanently lodged in their rectum or their vagina.
What? And there's nothing actually there?
Nothing at all. But the compressed nerve is misfiring so erratically that the sensory cortex up in the brain just can't make sense of the signals.
So the brain is just guessing.
Exactly. The brain's best guess at interpreting that chaotic data is to assume there is a massive physical object stretching in the tissue.
Oh my God, that sounds like an absolute nightmare to live with.
It is incredibly distressing for patients.
So you have a phantom golf ball causing you distress, and an invisible fiber optic cable that might be crushed or stretched. How does a doctor quantify that? Like, if you can't see the nerve on an X-ray, how do you measure the signal distortion?
Well, the initial evaluation is actually surprisingly low-tech. A doctor will typically start with a physical exam to test the sensitivity of the vestibular tissue, often using nothing more than a simple cotton swab.
Just a Q-tip.
Basically, yeah. They apply gentle pressure around the vaginal opening, usually mapping it out like a clock face. So they're testing at 12 o'clock, 3 o'clock, 6 o'clock, and so on.
Okay.
And if that light, normally painless touch reproduces the severe pain the patient has been experiencing, that registers as a positive test.
But wait, I'm stuck on this. If someone comes in complaining of pain, and you touch them with a cotton swab and they say, ouch, that just tells you that it hurts.
Right.
It doesn't tell you anything about what the nerve is doing,
Yeah.
right? It feels like we were just confirming what the patient already told us in the waiting room.
You've hit on the exact limitation of the basic physical exam. It confirms mechanical hyperalgesia, which is pain from a non-painful stimulus, but it doesn't give you a neurological map.
It doesn't show you the frayed cable.
Exactly. To truly evaluate the specific nerve fibers, clinicians have to move to a much more advanced form of mapping called quantitative sensory testing, or QST.
Okay, QST.
This is where we stop guessing and actually isolate the different types of cables inside that fiber optic bundle to see which ones are frayed.
Okay, I am fascinated by how you isolate a nerve fiber. Walk me through how QST actually works in a clinical setting.
So QST breaks down the sensory pathways into 3 main categories of nerve fibers and tests them one by one. First, you have the large A-beta fibers.
Oh, beta.
Right. These are responsible for communicating vibration and light, non-painful touch. Doctors test these using a handheld device called a biothesiometer.
Which does what?
It applies a very specific, measurable vibration to the tissue to see if the patient can feel it.
So that checks the basic, like, can you feel movement cable?
Yes. Next, they test the smaller A-delta fibers. These fibers transmit cold sensations and the first sharp, immediate component of a pain signal, like when you prick your finger with a needle.
That instant ouch.
Right. And finally, they test the C fibers. These are the smallest, unmyelinated fibers, meaning they are the slowest of the bunch.
What do they do?
They mediate hot sensations and that deep, slow, throbbing component of pain that sets in after an injury.
Like an ache.
Exactly. So by selectively applying measured vibration, cold stimuli, and heat to the pelvic region, the doctor can pinpoint exactly which threshold is broken.
Wow.
They can see the exact millisecond a patient feels warmth, or the exact temperature where warmth turns into agonizing pain.
So you are building a highly customized sensory profile. Have researchers used this on a large scale to see what is actually happening in women with pelvic pain?
They have, and the findings completely change how we understand pelvic health. There's this major initiative highlighted in the research called the TRIPP. Yes, Translational Research in Pelvic Pain. They performed comprehensive QST on women suffering from chronic pelvic pain conditions like endometriosis and bladder pain syndrome.
And what did they find?
The statistics were staggering. Among the women studied, over 50% showed profound mechanical hyperalgesia.
So normal, gentle pressure was registering as extreme pain.
Yes. And even more revealing, a mere 6.8% of these women had a healthy or normal sensory profile.
Wait, 6.8%? So almost none of them had normal nerve function.
Basically none. But the CHIA-PP study went further and revealed the most critical insight of all, which is the presence of central sensitization.
Okay, I'm going to play devil's advocate here for a second, though.
Go for it.
Even with all this high-tech mapping of A beta fibers and C fibers, if a patient is already in excruciating pain, does taking the time to poke them with hot, cold, and vibrating probes actually change their medical outcome? Or is this just, like, academic curiosity?
No, it fundamentally changes the medical outcome, and central sensitization is the exact reason why.
Okay, explain that.
QST distinguishes between a local nerve irritation in the pelvis and a software glitch in the central nervous system itself.
A software glitch.
Yeah, central sensitization means that after months or years of chronic pain, the brain and the spinal cord have essentially rewired themselves. The central nervous system begins to amplify normal sensory inputs from the deep tissues in the skin.
Oh,
It turns the volume knob up to an 11 on every signal coming from the pelvis. It interprets everything, even just the brush of clothing, as severe danger.
so the nerve in the pelvis might actually be fully healed from whatever the original injury was, but the brain is still sounding the alarm.
Exactly. The brain is stuck in an alarm state. And if a doctor doesn't know that, they might perform invasive surgeries on the pelvis or prescribe local numbing creams, and it won't do a thing.
Because the pain isn't in the pelvis anymore, it's in the central nervous system.
Precisely. If QST reveals central sensitization, the doctor completely shifts the therapeutic strategy to medications or behavioral therapies that target the brain and spinal cord rather than treating the local tissue.
That makes total sense. You are testing the sensory nerves to fix a sensory problem. But, as I was reviewing the literature for this deep dive, there's another test that kept popping up.
Let me guess.
It seems to be the most heavily utilized pelvic nerve test historically. But it doesn't test sensation at all. It tests muscle movement.
Ah, yes. You have found the pudendal nerve terminal motor latency test.
The PNTML.
PNTML, yes.
Yes. If a woman comes in saying she has chronic pain or she can't feel anything during intimacy, why on earth would a doctor use a test that measures a motor function?
It is the million-dollar question, and I will tell you it is the source of fierce debate in pelvic medicine right now.
I can imagine.
To understand the controversy, we really have to look at the methodology, which is quite invasive. To perform a PNTML, the clinician uses a specialized disposable device called a St. Mark's electrode.
What is that?
It's essentially a glove with an electrode built into the index finger.
That doesn't sound entirely comfortable.
No, it's not. The clinician places this gloved finger into the patient's rectum.
Oh, wow.
I will note that increasingly, some clinics perform this vaginally, which studies show yields very similar diagnostic results and is far better tolerated by patients. But either way, the doctor navigates to a bony landmark inside the pelvis called the ischial spine, which is where the pudendal nerve runs. The electrode delivers a small electrical shock to the nerve, and the device measures exactly how fast the anal or urethral sphincter muscle twitches in response.
So it's literally measuring the speed of the electrical signal traveling down the nerve.
Yes, it calculates latency, which is the time it takes for the signal to travel from the shock point to the muscle.
Okay.
The theory is that if the nerve is damaged, or if the protective myelin sheath around the nerve is degraded, the signal will travel much slower.
That makes sense logically.
And this test is incredibly useful for predicting the outcomes of muscular surgeries. Like if a surgeon is going to repair a rectal prolapse or treat stress urinary incontinence, they really need to know if the muscles and motor nerves are communicating properly.
Right, because those are mechanical muscular problems.
But historically, PNTML was heavily relied upon as the gold standard to diagnose pudendal neuralgia.
Which, as we discussed, is almost entirely a sensory pain condition.
Exactly.
Okay, let me see if I have this straight. Using PNTML to diagnose vaginal pain is basically like a mechanic testing how fast a car's windshield wipers move to figure out why the radio is broken.
That is a brilliant way to frame it.
Right, because they both run on the car's electrical system, but the wipers are a motor function and the radio is a sensory output.
Yes.
Measuring the speed of the wipers tells you absolutely nothing about why the speakers are making a horrible static noise.
Exactly. You simply cannot correlate the nerve conduction speeds of large motor fibers with the state of tiny sensory pain fibers.
They're different cables.
Right. A nerve can be incredibly inflamed, causing a patient agonizing, life-altering pain without its motor conduction speed being slowed down by a single millisecond. This fundamental flaw is why major medical bodies, including the American Gastroenterological Association, have vehemently discredited PNTML as a diagnostic tool for pudendal pain syndromes.
Plus, doesn't age throw a wrench into the whole speed testing thing anyway?
Oh, it completely skews the data. Studies clearly demonstrate that PNTML values naturally slow down as a normal part of the aging process.
Naturally.
Just naturally. So if a clinic isn't rigorously using age-stratified reference values, they might look at a perfectly healthy 60-year-old woman and diagnose her with severe nerve damage simply because her motor latency is slower than a 25-year-old's.
That's crazy.
It leads to rampant misdiagnosis.
So the takeaway on the testing front for our listeners is really clear. If the problem is pain or numbness, you need sensory mapping tools like QST, not a flawed motor speed test like PNTML.
Yes, you absolutely have to use the right tool for the job.
But I want to explore something else here, because even if you use the perfect neurophysiologic test and you map the nerve perfectly, sensory changes in the vagina are rarely just about the nerve itself. Because nerves don't just float in empty space, right? They live inside a tissue environment. And if that environment degrades, the sensation's going to change regardless of how healthy the nerve is.
Yes, and this takes us into a massive, heavily under-discussed area of women's health known as genitourinary syndrome of menopause, or GSM.
GSM. Is that what used to just be called vaginal atrophy?
It is, but the medical community updated the terminology because atrophy doesn't even begin to capture the systemic impact of what is actually happening.
Okay, so what is happening?
GSM encompasses the entire cascade of effects that occur when estrogen and testosterone levels plummet during perimenopause and menopause. People often don't realize that estrogen receptors are densely packed throughout the vagina, the urethra, the bladder, and the entire pelvic floor.
So they're everywhere down there.
Everywhere. And when that hormone supply is cut off, the physical architecture of the tissue fundamentally degrades.
What does that degradation actually look like, say, on a cellular level?
The vaginal epithelium, so the surface lining, becomes incredibly pale, thin, and friable.
Friable, meaning easily damaged.
Exactly. It means it tears very easily under friction. The tissue also loses its natural rugae.
Rugae.
Rugae are those accordion-like folds in the vaginal wall that allow it to stretch and expand. The tissue loses its collagen matrix and its elastin.
Wow.
So think back to your house analogy. You might have a perfectly healthy, pristine fiber optic cable running through the wall, but the drywall itself is completely crumbling, the insulation is gone, and the wood is rotting.
And the nerve is going to feel all of that damage.
Exactly. It causes severe dyspareunia, which is painful intercourse, alongside chronic itching, burning, and dryness. And importantly, no amount of nerve medication is going to fix that.
Right, because the nerve isn't the problem.
Because the nerve is just accurately reporting that its environment is falling apart.
So how do you rebuild the drywall? I know standard hormone creams are the frontline defense, but the literature we looked at highlighted some fascinating physical treatments aimed at restoring that tissue architecture.
Like energy-based devices.
Yeah, EBDs.
Energy-based devices, or EBDs, are completely changing the landscape here. The most prominent examples are transvaginal lasers.
Which sounds wild.
It does. There was the Gambacciani study from 2018 that looked specifically at postmenopausal women suffering from severe GSM who underwent fractional laser therapy.
How does shooting a laser inside the body rebuild tissue?
Well, it sounds counterintuitive, but it relies on the body's own healing mechanics. The laser injuries, these micro traumas in the vaginal mucosa.
So you're purposely injuring it a little bit.
Right. These injuries are tiny, but they trick the body into initiating a massive inflammatory healing response.
Oh, I see.
Fibroblasts rush to the area, depositing fresh, new collagen fibers and elastin, and stimulating the growth of new blood vessels. The Gambacciani study showed that this tissue remodeling led to massive, statistically significant reductions in vaginal dryness and dyspareunia.
That's incredible. It's forcing the body to renovate the room where the nerve lives.
Exactly.
I was also surprised to read about aesthetic procedures being utilized for sensory loss. Things like G-spot-plasty.
Yes, that is a much more controversial, extreme end of the spectrum.
Right.
G-spot-plasty involves harvesting autologous fat, meaning fat, taken from another part of the patient's own body, and injecting it directly into the anterior vaginal wall.
Does it plump it up?
To plump up the tissue around the G-spot, yes. The mechanical theory is that by increasing the physical bulk of the tissue, you increase the friction and pressure exerted on those sensory nerves during intercourse, theoretically reestablishing vaginal orgasms and sexual satisfaction.
It's wild to think about physically padding the area just to force the nerve to fire.
It is a very mechanical approach.
But for women who want a more conservative, non-surgical route, I noticed treatments focused on just waking the nerves back up, like the Kegel 8 pelvic floor trainer.
Yes, conservative therapies like biofeedback and electronic pelvic floor trainers are vital. Devices like the Kegel 8 use very mild, targeted electrical stimulation to involuntarily contract the pelvic floor muscles.
So it does the work for you.
It essentially forces the dormant muscles and nerves to wake up and fire. They also utilize biofeedback, giving the patient a visual or tactile cue of exactly how hard she is contracting her muscles.
Which helps her relearn how to do it.
Exactly, helping her actively rebuild the neurological bridge between her brain and her pelvis.
And that neurological bridge brings up something I found deeply compelling in the sources.
Oh, about the sensory speed bumps.
Yes. If a woman is going to use a biofeedback device or even just engage in physical therapy, she has to actually be able to feel and isolate her pelvic floor.
Yeah.
But there was this concept mentioned called sensory speed bumps.
Right.
It implies that sometimes the inability to feel the pelvis isn't a physical nerve injury at all.
This is perhaps the most profound insight in all of pelvic medicine, honestly. When a patient presents with vaginal numbness or pain, doctors have to figure out if it is a hardware issue, like a crushed pudendal nerve or thin tissue, or a software issue in the brain.
And a lot of times it's the software.
Often, women simply never developed healthy pelvic sensory awareness in the first place because of these sensory speed bumps.
What creates a sensory speed bump?
Well, think about the developmental timeline. If a young girl experiences agonizingly painful menstruation every single month, her central nervous system quickly learns to associate any sensation from the pelvis exclusively with trauma.
Oh, wow. So it just blocks it out.
The brain's natural evolutionary defense mechanism is to blunt, ignore, or actively mute the signals coming from that area to protect her from constant distress.
That is so sad, but it makes so much sense.
And add to that chronic yeast infections, urinary tract infections, or even just overwhelming societal taboos that teach young women that the pelvic region is dirty or shouldn't be touched.
The brain just shuts the channel off completely.
It does. So by the time that woman is 40 years old and trying to use a biofeedback device to cure her sensory loss, her brain literally does not have the established neurological pathways to interpret the signals.
The hardware might be fine, but the software was never installed.
Exactly, and treating that requires a deeply holistic approach. You might need physical therapy to address the tissue, alongside cognitive behavioral therapy or sex therapy to help the brain safely remap that part of the body.
The sheer complexity of this is just staggering. We started this deep dive by asking if nerve testing can evaluate vaginal sensation changes, and the answer is clearly yes, but with massive caveats.
Huge caveats.
You have to use sensory tests like QST for sensory problems and ditch the flawed motor tests like PNTML. But more than that, you can't just look at a nerve fiber in isolation.
No, not at all.
You have to look at the hormonal drywall it lives in, and you have to account for a lifetime of psychological programming that dictates how the brain reads those signals.
It is a beautifully, frustratingly interconnected system.
It really is.
And, if you follow the science of central sensitization to its logical conclusion, this idea that chronic pelvic pain and sensory loss physically rewire the brain's software over time, it raises a question about the future of medicine that is, frankly, mind-bending.
Okay, lay it on me. What is it?
If the pain and the numbness are ultimately being dictated by a hyperactive central nervous system, could the future of treating vaginal sensation move away from the pelvis entirely?
What do you mean?
Imagine a future where we utilize virtual reality or advanced brain mapping interfaces to directly reprogram the sensory cortex.
Wait, really?
Yeah, curing pelvic pain or restoring intimacy, not by touching the body at all, but by treating the brain.